why does our government want payment by results? Well, they're looking for something that's much more transparent than the current system of contracting and payment. And what they're looking for is a rule-based system for paying providers. They want to reward efficiency, they want to support patient choice and diversity. And they want these contracts to move towards ones where you're paying for activity. They want it adjusted for case mix. This is not dissimilar from the presentation this morning, from a plurality of providers. So it isn't just about big mental health care organizations. And what they want, and this is the key to payment by results, is to develop a standard national tariff that will be adjusted for regional variation in demand from the population based upon the population demographic, and also adjusted for case mix. But they're looking for national tariffs for payments for care packages. Now, those are the high-minded reasons why the mental health world wants payment by results, but the kind of slightly more low-minded reason is the fact that the acute sector has moved into this in a big way. I think it's about 40 to 45% of the funding of medical and surgical services is now done through payment by results. So the idea is that the data set that underpins payment by result, that from that we'll be able to develop indicators of quality of mental health care that will allow for comparison between providers. It's going to help the government deliver national policies, because by changing the value of the tariff, by adding bits to it, by changing the way that services are costed, they can actually drive through the implementation of their vision of how mental health services should be. Currency, the way that term is used in England, it's the unit for which payment is made. So it is simply it's a defined object that is the object for which you pay, and the tariff is the price for that unit. Now, the object will remain the same, but the tariff, the price, can change. The government can kind of put a squeeze on services and reduce the tariff, but the thing you're buying will remain the same. The idea is that what underpins payment by results is that every patient will be assessed using what is called the mental health clustering tool, and I'm going to be telling you much more about that in a minute. Once you've done your assessment, the patient is then allocated to one of 21 clusters based on the assessment, and these clusters are the currency. These are the units of payment for commissioning. And the idea is that once you set the tariff, this financial risk will be shared between the person paying and the person providing. So as in the States, if you can deliver care to a person in a particular cluster for less than the cost of the tariff, then well done, you can keep the difference. If it costs you more, then bad luck, you're going to end up with a deficit. So there's this kind of risk-sharing arrangement. And the idea is that payment should be for all elements of care. So you're not paying for items of service. It's both the kind of direct treatment, so it's for the medication that's prescribed, the therapy that's given, but it's also for all the indirect costs of, for example, the time of coordinating care, the downtime for clinical staff. All of those costs have to be built into the tariff that is used to pay for the particular currency. Now, the clusters, what are they? They basically fall into three families, and as you can see, they're recognisable to a clinician. There are clusters that sit under as non-psychotic conditions. You've then got ones that are psychotic and organic, and under those, here they are. So you've got 8 clusters sitting under non-psychosis, which fall into 2 groups, those that are mild, moderate and severe, and those that are very severe and complex. Under psychosis, you have 10 to 17, there's 8 clusters. And under organic, you've got 4. Now, how's it done? Well, first you assess the patient, and a bit like with HONOS, you don't sit there with a thing in front of you going through it like a semi-structured interview. You undertake a full assessment. Ideally, you should be working with your team on the rating, and I've got to say, you should also be, and this came up yesterday, you should also be sitting there. You should also be sharing it with the patient and getting them involved in the decisions. And then you use the mental health clustering booklet, which has grids that should guide you to making the allocation